All right, good afternoon, everyone who's joining us here in person at the National Press Club in Washington, D.C., and good morning or afternoon or whatever time it is where you are. For all of you who are joining us online, we really appreciate your being with us for this important event as well on reimagining our shared approach to fall respiratory virus season. These are where we'll talk about new strategies for transmission reduction and their population health benefits. I'm Mark McClellan. I'm the director of the Duke Margolis Center for Health Policy at Duke University, and very glad to be with you for this session at an important time as the U.S. is entering the fall and winter respiratory season with a much more comprehensive set of products available to limit the spread of influenza, respiratory syncytial virus, and COVID-19, some of our most important respiratory disease threats than ever before. These products consist of diagnostics, including population screening technologies like wastewater screening, over-the-counter tests that people can use directly, so-called lab or PCR tests, genomic tests, multiplex tests that can test for multiple viruses at the same time, as well as new therapeutics and new vaccines, including updated flu vaccinations, COVID-19 vaccines, and a new RSV vaccination. Coupled with the non-pharmaceutical interventions that are available to influence disease spread and impact, these improved products can help prevent, detect, and limit the severity of health consequences of infections for each person who uses them. But they also can help do more to contain the spread of these infectious diseases, benefiting many Americans who don't have ready access to or choose not to use these treatments themselves, further mitigating the impact of these important infectious diseases. Additional biomedical innovations could build on these successes, enabling even greater progress in containing infectious disease, such as therapies in development that not only prevent severe infection or death, but also hold promise for avoiding contraction and transmission of viral infections. These kinds of treatments have additional benefits for individuals. You'll have shorter symptoms or maybe no symptoms at all, but they could also have greater benefits for population health through a larger impact on transmission through that better protects high-risk contacts of people in the community around those who might otherwise have been more severely infected. Now, the potential benefits of transmission reduction for population health, what I'm talking about here, have long been recognized. But U.S. and global public policies don't necessarily have clear, well-developed frameworks for routinely assessing, valuing, and where they turn out to be important, supporting the development and use of biomedical innovations that have these population health impacts beyond their benefits for individuals. The absence of this kind of clear policy framework and guidance on potentially important biomedical opportunities for reducing transmission has significant public health implications, especially in settings like the U.S. and many other countries where there's only limited support for vaccine or treatment mandates to contain infections and improve public health. Current regulatory coverage and payment policies help encourage the use of vaccines and therapies that are safe and effective, but they may not fully reflect the potential benefits of more widespread use of products that do more to reduce transmission. Both because some individuals may be more willing to use a product because it's more protective for those at risk around them, and because policy reforms may influence the extent to which those products, really any products, are used in ways that could reduce transmission, progress in these areas is important. So as we see more progress in biomedical innovation, these kinds of steps to support population health improvement are likely to become more important and therefore a rising area of policy attention. An enhanced policy focus on transmission reduction could both help encourage new technologies that do more to reduce transmission and could also result in a greater impact of the existing diagnostic therapeutics and vaccines that we have. Evidence-based policies that encourage greater use of all of these products could reduce the risk of not only severe infections in individuals, but could support voluntary changes like staying home for people who find they have symptoms and may be transmitting, and also reduce the burden or the likelihood of those people to transmit infections. So today we're going to focus on this topic. We're going to talk about a shared, potentially systematic policy framework to account more explicitly for the population health benefits of transmission reduction, with the goal of achieving more effective progress in containing infectious diseases without mandates, without requirements, without other steps like that. This framework incorporates key dimensions of population benefits to support policies that account explicitly for the value of transmission reduction in conjunction with the individual benefits of biomedical products. We include some examples of policy actions that reflect this kind of framework. We're going to highlight implications of the framework for regulatory, coverage, and payment policies, and we're going to do that with an illustrative focus on the implications for better reducing or blocking the transmission of major respiratory viruses, certainly a front-of-mind issue right now. All of this discussion is going to be couched in that respiratory virus framework. So let me just, before we get going, a few other preliminary issues. We want to remind everyone that the Margolis Center for Health Policy, as part of Duke University, honors the tradition of academic independence on behalf of its faculty and scholars. Neither Duke nor the Margolis Center take partisan positions. What we really want to see happen is individuals being free to speak their mind, expressing their opinions on diverse and important issues like the ones we're talking about here today. And personally, I want to list a few disclosures. I'm an independent director on the boards of Johnson & Johnson, Cigna Lyman Healthcare, and Prognomic, and I co-chair the guiding committee for the Healthcare Payment Learning and Action Network, and receive fees for serving as an advisor for Arsenal Capital, Blackstone Life Sciences, and MITRE. And I also want to acknowledge support from the Gates Foundation for the areas of work that we're going to be talking about today. Let's see, next slide. Very important, we want these discussions to be interactive. So for those of you in the room, there's the QR code for helping to contribute to the discussion by submitting questions or comments. For those of you who are virtual, you can also use the Slido Q&A function. Use the code transmission after you go to slido.com, or you can scan the QR code on the slide that's up here and that should be available online too to access the platform, and we'll try to get in as many of these comments and questions as possible. And just a little bit of an overview before we get going. As you can see, we've got a number of topics to cover related to this important set of issues we're discussing today. We're very pleased to start with some remarks from CDC Director Mandy Cohen about public health and policy priorities in light of the fall respiratory virus seasons and ways in which medical technologies and healthcare collaborations can help improve public health. We'll then move into a discussion about the burden of this current fall respiratory virus season as we think about existing efforts that are underway to use diagnostics, therapeutics, vaccines for curbing disease spread. Then our next session will turn to a deeper discussion of our white paper, our discussion paper that was published alongside this workshop, which presents a potential shared framework for reducing transmission of respiratory viruses for population-level benefits and some of the potential implications for policy. And this is a discussion paper. We want to use this to get the conversation going. Then the next session will focus on actionable regulatory coverage and payment policy reforms to promote the development and successful adoption and use of these types of products. Finally, we'll conclude with a session on looking forward to how the kinds of issues we discussed today can support collaborative responses between public and private stakeholders to reduce the burden of respiratory viruses. I'm very pleased we've got such great panelists with us today to share a range of perspectives on these topics, and again, encourage all of you to contribute as well. So with that, let's get started. I'm very pleased to welcome Director of the Centers for Disease Control and Prevention, Mandy Cohen, to provide some opening remarks on current public health priorities, particularly related to the 2023 respiratory virus season and the policy outlook related to the topics that we're going to discuss today. So let's hear from Mandy right now. Or shortly.
Hi, everyone. I'm Dr. Mandy Cohen, Director of the CDC, and I really wish I could have been with you all today to discuss our work to reduce respiratory disease transmission this fall and winter season. I'm really grateful for you coming together to work on alignment between public health and health delivery to meet the challenges that the respiratory viruses bring us each and every year. This conversation is foundational as we think about overall alignment between health delivery, public health, and other sectors like life sciences, social supports, philanthropy, academia, and much more. While we see more health threats than ever on the horizon, the good news is that we have an unprecedented moment of scientific breakthroughs, powerful detection and diagnostic interventions, artificial intelligence advancements that are game changers. And so with more challenges, but also more innovation than ever before, the question facing all of us now is, what do we do? What do we, public health and health delivery, need to do to meet this moment? To embed the lessons of the pandemic, to create an integrated system to protect the health of this country. I want to share a bit about what our team at CDC is doing related to our fall and winter response. We're really using this fall-winter virus season to turn a new chapter and chart a path forward. Specifically, we're thinking about policy development differently. Our public health policies, of course, must always be science-driven, evidence-based, but we really need to consider the real operational and implementation realities. For example, when the RSV infant monoclonal antibody, nirsevimab, was being rolled out, we did go beyond just putting out those evidence-based recommendations into the world. We collaborated with the delivery system and worked with the American Academy of Pediatrics, the American Medical Association, and CMS to make sure pediatricians could be reimbursed not only for administering the new RSV immunization for babies, but also for counseling families about it. But we have more work to do on the coverage front, from both a policy and operational perspective. Today, if a child needs a vaccine recommended from the CDC, we have the Vaccines for Children's program, and they can get those vaccines for free if they're uninsured or on Medicaid. Unfortunately, no such infrastructure exists for adults. This year, with the COVID-19 vaccine moving to the commercial market, the CDC's Bridge Access Program provided that COVID vaccine to adults who are uninsured and underinsured for free. But we need a longer-term solution because the Bridge program is just that. It's a bridge. This is going to take partnership with Congress to create a permanent Vaccines for Adults program to provide access to life-saving vaccine and be better prepared to respond to the next emerging public health threat. We also know that respiratory virus season will happen every year, and that's why the CDC, in order to respond effectively, needs data to flow. It needs it to flow between states, to and from the CDC, between public health and healthcare, and we need that to happen as quickly as possible. We need adoption of data standards and system functionality, and we are working closely with our federal partners at ONC and CMS to implement a public health system certification program to promote interoperability and functionality for core data systems. We've also been working hard and fast to put in place forward-looking data use agreements, or DUAs, with our state, local, tribal, and territorial partners to enable robust national situational awareness. Specifically, we're introducing a common DUA for all our core data sources with our health department partners in the next month. We're also looking at the full range of policy levers to both maximize our current authorities and build on them through partnership with Congress. Among other things, the goal of this effort is to provide Americans a more complete understanding about what's happening in their community related to COVID, flu, and RSV. We've been working with our jurisdictional partners to allow us to visualize data, prioritizing the National Syndromic Surveillance Program, with the goal of having at least 20 jurisdictions allowing public visualizations of respiratory virus emergency department diagnosis to the sub-state level this season. Without our jurisdictional partner approval, we are not able to share such data at that level of granularity. So now we have the ED data visualized at the state level, but we need to do better. As you engage in discussion today, I appreciate your focus on health delivery and public health alignment and thinking creatively about how to utilize the regulatory and reimbursement processes to focus on our shared priority of reducing the burden of respiratory disease. We need an integrated effort to keep this country protected and healthy. This is a team sport, and I'm grateful to have you on the team. Thanks so much.
All right, Mandy, thank you very much. So we're now going to transition to some further discussion of those issues that Mandy raised, including healthcare and life sciences, working together with public health and communities to encourage the development and effective use of these new technologies. But to kick that off, we want to have an introduction to where we stand now with respect to the fall respiratory virus season to get going in our first session on the burden and spread of respiratory viruses this fall. So to provide a high-level overview of that, I'm very pleased to introduce Caitlin Rivers, who's Senior Scholar at the Johns Hopkins Center for Health Security and the author of Outbreak Outlook, which is a timely weekly update on everything current in infectious disease spread in the U.S. It's okay for me to give a plug for that, right? Okay, great. Thank you, Caitlin, for being with us.
All right, good afternoon, everyone, and thank you for that introduction. It's great to be here with you all, especially with Dr. Cohen. It's good to see her introduce our remarks today. And as Director Cohen mentioned, it's so important that we're coming together today as a team for a chance to really make a difference in seasonal respiratory virus season. If there's one thing I want you to walk away from this first session today, it's that even an easy year of a seasonal we really need a shorter name. I'm going to say flu season, but we all know it's not just flu. Even an easy flu season is not easy for healthcare providers. It's not easy for families. It's not easy for children who are often most affected. And so we really do need to come together to do more to reduce the burden of flu season. Now, a few words on what's happening so far this year. The first piece of good news is that so far this year is better than last year. You may remember that this time last year, the triple-demic was well underway. RSV was at probably record highs, and it was hitting children hard. And at the same time, we also had an unusually early start to the flu season. Once again, it was difficult for the pediatric healthcare delivery system to manage that surge in patients. It was difficult for families who have to go to work. I have 2 preschoolers and an elementary school student, and I can tell you we were home a lot last year, and that is not easy. It's hard for people who are on hourly wages. It's all around a very difficult situation. And so I'm happy that this year is not quite starting off with quite the same bang as last year was, but again, that doesn't mean that it's easy. The second major virus that I think about when I think about flu season is COVID-19. Now, it didn't used to be the case as recently as 2019 that we had COVID-19 as a burden to manage during flu season. And so the good news is that right now it's not as high as it has been in years previously, but we do see that activity tends to increase through the fall months and peak in autumn. And this pathogen is additive to the pathogens that already circulate during flu season and already create that substantial burden. And so it's really setting a new high watermark for the kinds of burden of seasonal respiratory disease that we will have to manage. The third virus that I think about when I think about flu season is, of course, influenza. Last year was an unusually early flu season, although the peak was not as high as it is in very severe years. But because it came so early, a lot of healthcare delivery systems were not quite ready and struggled to manage under that unexpected burden. This, right now, we're not seeing quite as early of a flu season as we did last year, but just as of yesterday, the data was released that show that we have now crossed the threshold that marks the start of flu season. And so it's coming for us, especially in the Southeast. There are already states that are recording moderate and high levels of influenza-like illness, and soon I think we'll really see that all over the country. I do want to go back briefly to RSV and say, although this RSV season is not shaping up to be quite as bad as it was last year, we are still seeing a very high burden of RSV, particularly in children. If you look at southeastern states like Florida and Georgia, their hospitalization rates are actually similar to what we saw last year. And again, that was a very unusual year with the triple-demic. And so although it's somewhat reduced from last year, it's still a pretty serious situation. And so with those three pathogens, flu, COVID-19, and RSV, it is a lot to manage. Another point I want to make is that this is basically what I think we can expect in flu season going forward. I don't think we're going to return to the 2021 year when very little circulated. I think that this is the kind of activity that we'll see from here on out, and that means we need to be, one, planning for how to manage this level of burden, and two, exactly what we're doing today, thinking about how we can come together to slow circulation and reduce the impacts on communities, families, and hospitals. I do have a few other little points of good news. I try to bring as much good news as I can because often these epidemiology conversations are difficult. This is the very first season that we have medical countermeasures for all three of those pathogens, and I think that is a big reason to be excited. We continue to enjoy the seasonal influenza vaccine. I got mine a couple weeks ago. We now have the annual COVID booster, and this is the first year that there is a shot available to protect infants and older adults. I think this is a wonderful development, and again, I'm so excited about it, but as we learn time and time again, a vaccine is not a vaccination. It's really the administration and distribution of those products that there is opportunity for impact, and I think that where the rubber meets the road, that's a place where we have room to grow. For one thing, uptake of vaccines is not at an ideal level. At the end of October, influenza vaccine coverage was only 28%. I think it may have climbed a little bit more recently to around 34%, but that means that 65% of adults have not yet received their flu vaccine. COVID vaccine coverage is even worse. It's about 10%, which means 90% of people have not gotten their annual COVID vaccine. And RSV vaccine uptake among older adults was also pretty low. What concerns me especially is not just that coverage is low, although we should fix that, but a significant 41% of individuals said that they are definitely or probably not planning to receive the COVID-19 vaccine. So it's not just that they haven't gotten around to it or they're trying to find a good time in their schedule. 41% of people say they don't plan to get it, full stop. I find this really concerning. There have also been some challenges with shortages. The RSV product for infants has actually had more demand than expected, which is a good problem to have, better than a refusal. But there have been problems getting that product out to families who want it. Now, I must mention that I discovered that data on coverage just yesterday, and it's very recent. It's consolidated on a single page, and it's updated regularly. So I do want to extend my appreciation to CDC and to Director Cohen for her leadership on the matter of prioritizing seasonal respiratory virus activity. The fact that I was able to find that information, that it was all right there, that it's updated regularly, that's actually a really big step forward to what we've seen in years past. And it's only with that kind of light shining on the information, it's only with that visibility that we can really start to understand what the problem is and therefore where we can make advances. There's one other topic I want to cover, and that's the point of the other category of respiratory viruses. There are dozens of respiratory pathogens that infect us regularly. We live with them year-round. We hardly even know it, and we surveil for them very minimally. This category includes adenoviruses, parainfluenza, metapneumovirus, and the seasonal coronaviruses. It's a long, intimidating list. Many of those are actually umbrella categories that have many subviruses under them. And it continually astounds me that our understanding of the epidemiology of those viruses is very limited. And when you get infected with one of them, which I assure you, you do probably most years, you'll never know it because we don't do the kind of diagnostic testing that would deliver a confirmatory result for those pathogens very often. It's usually only in people who are hospitalized with severe illness that you would get a definitive diagnosis of infection with one of those pathogens. So I think to truly make progress in combating seasonal respiratory viruses, not only do we need to be doing what we're doing here today, not only do we need to be discussing how to make a vaccine a vaccination, how to extend health policy to make those products affordable and accessible to people, but I think we also need to improve surveillance and deepen our scientific understanding of the epidemiology of those other viruses. I think it's critical for effective action, and there's a second significant upside, which is that if we do a good job surveilling for these other pathogens, we'll also be in a better position to surveil for the next unknown threat, the next disease X. And I think the next one could be sooner than any of us wish, because that is often, I think, the case. Many people like to comment on the fact that COVID was a 1 in 100-year pandemic, but in fact, it's about every 2 years that something pops up that has me on my toes. And so I think we need to be thinking about how we can expand our surveillance of seasonal respiratory pathogens, including these other ones, and to leverage those systems to be able to look for the next threat. Thank you.
All right, Caitlin, thanks very much for that overview to introduce this session. I'd like to invite up our panelists to the stage who will be joining us for this discussion. Do you mind scooting over one more? Sorry. And that includes one panelist who's with us virtually, Ann Zink, joining remotely from Alaska as Chief Medical Officer for the Alaska Department of Public Health and immediate past president of the Association of State and Territorial Health Officials, where she's been extensively involved in these same kinds of public population health issues. Also pleased to be joined by Sid Tanetti, who's Senior Vice President of Retail Pharmacy Growth and Omnichannel at CVS Health, Brandon Webb, Associate Professor of Research and Director of Infectious Diseases at Intermountain Health, and Christian Reimers, who's Assistant Medical Director for Research and Special Populations and the Director of Graduate Medical Education at the Family Health Centers of San Diego, where I know from all of our interactions over the last few years, he's been directly involved in a lot of these respiratory disease threats and the vulnerable populations they disproportionately affect. So looking forward to some opening comments from all of our speakers, but Caitlin, first, one maybe fairly quick, maybe provocative question for you. You described the trends that we're seeing in these outbreaks. What's your sense of whether all these new technologies, these new medical countermeasures that you mentioned, the diagnostics, the therapeutics, the vaccines, are they having an impact so far, given what you've also noted about limited uptake?
I have not seen very much evidence that the availability of these products is reducing the course of this season compared to last season's. Where I think we can expect and hope to see an impact is in burden of severe disease. So I don't expect to see a lot of reduction in transmission, but as the season goes along and as we get further into that epidemic curve where the burden of these diseases really starts to surge, I hope to see that we have fewer hospitalizations and fewer deaths.
Okay, so I'd like to turn to each of you all now for some opening comments on this discussion. I guess I'll just go down the line if that's okay. Brandon, starting with you.
Certainly. Yeah, I appreciate your comments, Dr. Rivers. I wanted to actually just touch on a couple of things that you mentioned because I think it's really critical, from a healthcare delivery vantage, which is where I'm coming from primarily. And especially from the vantage of value-based care and from public-private initiatives and from the standpoint of how do we do the most good with the resources that we do have. I love that you touched on two things. One was that delivery is different than having availability, and that vaccines are not vaccination. That's something that we really need to focus on. And the second, I think, is how do we drill down and understand why we have these disparities and these gaps where people aren't using the products and tools that we have. I think at the end of the day, it's still just as much about behavior as it is about biology. And our window of opportunity right now allows us to reframe our policies and our healthcare delivery in a way that we can look creatively at strategies that incentivize linking behavior with biology. I'll just give 3 quick examples. One is we really need to move into a new framework at looking at COVID as one among many among respiratory viruses. It needs to be integrated into our overall strategy. We also need to find new metrics, new indicators, which actually aren't new at all, but we need to find indicators from different perspectives like productivity lost, like actuarial insurance, like population health metrics, like antimicrobial resistance because of overuse. All of these things are downstream consequences. And I think that using new metrics or looking at metrics in a different way can actually help change behavior. And then finally, I would argue that with these new tools and all of these wonderful new innovations, we also need to implement risk-adapted strategies to make sure that we're using those tools in populations where they're most likely to benefit, where the cost effectiveness is there. And I think that one of the challenges for us is actually to reintroduce the concept of number needed to treat into public health. Thank you.
Great. Thanks very much for those opening comments, Sid. And as I was going down the line, I forgot. I really need to start with the virtual part of the line. So, Anne, thanks for being with us. I know it's been some tough weather up there in Alaska with the cold recently, and really appreciate with all else going on that you're able to join us today.
Yeah, no, thanks so much, Mark, and thanks to everyone at Duke Margolis for having this. I appreciate the opportunity to join virtually, although I'd much rather be in person, but between numerous travel snafus, here I am. So I really also highlighted, and I'm just going to build off of Sid's comments right there. I think sometimes public health is put into a side corner. As mentioned previously, I'm the Chief Medical Officer for the state of Alaska and the past president of ASTO, the Association of State and Territorial Health Officers. But I'm also a practicing emergency medicine physician. And the separation between public health and healthcare, and we see this all the time in respiratory diseases as well as numerous other diseases, is this chasm that we have the American public falling between. And so I think we need to think about not just population medicine, but population health, not just from a medical standpoint. And just as Sid had mentioned, thinking about the metrics associated with that and thinking about the whole landscape from everything from diagnostic all the way through testing and treating. I wanted to build on a couple of things that Mandy Cohen had mentioned previously. It's been great to see a lot of the work that's happening, including adult vaccines, the data use agreements, and while those seem small and frustrating from a public health state perspective, they're incredibly huge and can make a really big difference to get data to transfer more easily. The certification also, I think, is going to make a big deal. An adult vaccine program is gigantic, specifically because we know that kids don't live by themselves, adults don't live by themselves, and we live in community. And it's the more that we can think about respiratory diseases as a whole, rather than just in kids or versus adults. I also want to highlight the work that CFA, the Center for Forecasting and Outbreak Analytics, is doing, really braiding together the healthcare sector, the public health sector, and the private sector, and thinking about respiratory diseases. And it's been a really new way to allocate funding and being able to look at problems. And it's been really exciting to see from this end, CDC thinking about how they're allocating funds and solving problems differently than they ever had before. I think at the end of the day, to have better health, we need better information. And so I just wanted to go through 4 quick categories where in respiratory season, we need better information for better health. The first one's better healthcare data to public health. So all sorts of things in this category, including hospitalizations. In Alaska, our pediatric hospital beds are still completely overwhelmed and full. Early on in this respiratory season, we're only in November, and we're having regular meetings, but we can't see what other hospitals have well. And we know that hospitals transfer between other states, even Alaska down to Washington, and much more so in the lower 48. And so being able to see a universal way seeing hospital bed capacity really allows us to be able to have a better understanding of the overall burden on respiratory diseases and make sure that the right resources get to the right patients. I highlight the fact that we're focusing on respiratory diseases right now because I kind of feel like it's the first car in the car crash during the respiratory season. While it is just one thing, it impacts everything else. If your emergency department is boarding patients with COVID and flu and little kiddos with bad RSV, you're not able to take care of the heart attack, the cholecystectomy that needs to come out, the stroke, and all of the other things that come into the hospitals as a whole. And so I think that focusing on the variability of respiratory diseases will help us think about the variability in healthcare and public health as a whole, and makes a lot of sense as that canary in the coal mine. Also, treatment and location of treatment is a huge aspect for healthcare and public health data. So for example, as it's so great to have a monoclonal antibody to be able to get out to RSV to help reduce the risk of hospitalizations, just being able to see where those doses are and being able to administer them, as well as having better forecasting. As Caitlin had just mentioned, we had huge demand this year, which is absolutely fantastic. But the reality is we have about the same number of births every year, and this is not a particularly bad respiratory season. And the gaps in the data to being able to see the burden of disease and the expectation, and then this huge gap in actually being able to administer it has been a huge problem for states in trying to figure out how do we get out the very few limited doses that we have to the kiddos who need it the most in a rough respiratory season. The third thing I want to highlight in that healthcare to public health data is really the payment. I'm really excited for the future panelists to talk about this. We're seeing an increasing gap, particularly with Medicaid and Medicare patients who are unable to get vaccination and unable to get treatment because of the cost. And so public health departments oftentimes absorb the cost for cheaper vaccinations such as influenza. In our state, last year we had about 11,000 patients who qualified for Medicaid and Medicare that we just vaccinated on our own because we knew that they needed it. But we don't have the finances to do that for Paxlovid, monoclonal antibodies, for COVID now that it's on the private market. And that intersect between the private sector and the public sector is becoming really large, particularly in the Medicaid and Medicare space. Even when Medicare and Medicaid pay for those, it is oftentimes an additional burden. It's inadequate. It's additional vial that you have to order. And there's a lot of, as Caitlin had mentioned, getting a vaccination into a vaccinated person, being able to do that final mile. We're seeing the regulatory and payment aspect making a big deal. The second major category is public health to healthcare data. So being able to have things like vaccine status available to healthcare providers, this is becoming a really big challenge right now with RSV. A mom gives birth to a baby and we don't have access to monoclonals for that baby. Is mom vaccinated or not? Can they look in their record? Can they look in the chart? Do those even cross between the two? There's a lot of HIPAA concerns in that space. And being able to see vaccine status for that dyad, as well as vaccine status for COVID and RSV, is becoming a really large challenge. The respiratory roundup that CDC has been able to put on, again, I'm just going to highlight what Dr. Rivers had mentioned about being able to see weekly updates now is a big change from before, and it's huge. So our state has started to copy and use some of the things that CDC has been able to put out, which has really taken off the burden on our public health team, and being able to get an entire respiratory roundup weekly update. I would love to see the public sector be able to be more involved in that and being able to think about modeling moving forward. The next thing is data for policymakers, and I think this really hits into that population health data component. Being able to understand what is the impacts if you don't vaccinate your staff at a hospital. How many staff are you planning to not be able to have in working and would be out that respiratory season? So being able to do real-time modeling for understanding what that data is going to look like, and being able to make healthcare decisions as well as population health decisions based on that data. And then data for individuals, being able to have data driven in people's hands. I continue to just be amazed at how much we put into our economic forecasting, our weather forecasting, but we really don't have a national way to do basic health forecasting, particularly respiratory forecasting. We're starting to build that up, but as a result, it's making it very hard for public health sector, for healthcare, as well as individuals to make decisions for themselves and their community as a whole. The last thing I just wanted to highlight is the fact that we've seen almost a 46% decrease in the public health workforce, and 1 out of 5 healthcare workers have left the field in the last 5 years. And so we are asking the response of this burden, the burden of this response is much greater now than ever before. And so the more ways that we can think about simplifying the data and regulatory space so that we have systems working for patients instead of patients working for systems, I think we'll stop some of the moral injury that a lot of our providers have felt, and be able to really support the workforce moving forward and have a more robust response for whatever pathogen lies forward. So appreciate the opportunity for some remarks and looking forward to the rest of the panelists.
Thanks very much, Anne. I really appreciate the emphasis on how hard it is to have a coordinated, effective response without shared, up-to-date, accurate data, which, as you pointed out, is increasingly with these diagnostic and other technologies, electronic data technologies coming from healthcare. So I'm reminded by my team that the order that you all are planning to go in is a little bit different than the order on the stage, so I'm going to go next to Sid, if that's okay with you.
Sid Tinetti, like was mentioned, I work at CVS, and I'm really Glad to be part of today's discussion, and I'm really honored to represent pharmacy. Over the last 2 years, we've had a really big role, and we're really proud of the role we played in COVID. Both with all those innovations that were talked about, we had a big role in the distribution of those innovations, and I think it's a great example of public and private sectors coming together and deploying their strengths, individual strengths, for the greater good. I'd like to use my time to talk a little bit about how these innovations are actually playing out in the marketplace, since we are so close to them. We have the advantage of both national scale as well as local presence. So I think I can share a little bit about that. When it comes to COVID, when we think about some of the new tracking tools we have, we find that wastewater levels are closely correlated with over-the-counter test kits. More and more Americans are transitioning to over-the-counter test kits, which are then tightly correlated to COVID levels. If we take those three to be true, as those three are harbingers or indicators, then what we are seeing is that perhaps, fingers crossed, really early signs of a seasonal pattern, and it looks like 2021. So a high peak in August, coming down over the fall, but then to Caitlin's point, picking back up in December and January. That's what we think will happen. That's what happened in 2021, and that's what the data tells us. So really good tracking tools that we didn't have. Now, to the point made earlier, we need to deploy these more. More people need access to these. We need more data. But even what we have right now gives us some better visibility than we had in the past. I love what you said about vaccinations. I'm going to steal that. A vaccine is not a vaccination. It's actually the distribution. We're really lucky that we have 3 of those right now to combat the 3 respiratory diseases. If I think about flu, and where I share perhaps the most concern, is if you look at flu vaccine uptake over the last few years, it has steadily been increasing until the pandemic. And we are now seeing flu vaccine uptake come down. Now, we are still seeing retail pharmacy give a fair amount of vaccines, but overall, we are seeing uptake at the national scale be much lower than we had seen before. In fact, if things go the way they are, we're projecting that we would see flu vaccine uptake go back to 5 or 6 years ago, which is really a setback when you think about all the progress we've made from a vaccine perspective. Tied to that, when we look at infections, because the other thing that we have close visibility to is we look at Australia. If you look at 17 of the last 20 seasons, what happens in Australia from an infection perspective is a good indicator of what will happen in the US. And to Caitlin's point, in Australia, it was an early season, not as early as last year, but it was earlier than average, and it did spike a little bit lower than previous seasons. Now, that's only good news if you have vaccine uptake at the same rate, right? If your defenses are not as strong, even a slight spike will be problematic for us. From a COVID perspective, it'll be no surprise to anyone in this discussion or anyone who's being the reviews. It's really a tale of 2 states. Higher volume states tend to do almost twice the amount of vaccines as lower volume states. And there's no correlation between flu vaccine uptake and COVID vaccine uptake. We see states which have really strong flu vaccine uptake, like Florida, like South Carolina, like Texas, have really low COVID vaccine uptake. So it's all about the politics, and it's really about a tale of 2 Americas playing out in the states. And then, of course, RSV. We're incredibly grateful for that vaccine, I think, and we've seen really strong demand. We do 60 plus. We do the seniors in our pharmacies, and we've seen really strong demand, paralleling the demand that we see for the high-dose vaccine we give to seniors. So really good tools at our disposal. Our pharmacies are projected to give tens of millions of vaccines in the next 3 months, starting in September through December through the season. We're really proud of the work they do. But I think the takeaway for all of us, and why this discussion is really helpful, is there's so much more work to be done. I'll just leave you with one data point. If you triangulate what the manufacturers are saying and what we are saying, we project best case scenario, you're looking at a 15 to 17% uptake for COVID vaccine, which is staggering considering where we were a couple of years ago. Look forward to the rest of the discussion.
Okay, great. Thanks very much. A lot to think about there, Sid. Appreciate it. Christian?
Yeah, thanks, Mark. I'm Christian Ramers, infectious disease physician in San Diego, and I work in an FQHC, a large 23-clinic system with 200 primary care providers and nurse practitioners and PAs actually carrying out the primary care for about 200,000 underserved individuals. And I didn't want my talk to be all bad news, but I'm here to tell you the reality of what things look like for a poor person in America. The last mile, as Dr. Zink said, the best public health intervention doesn't do any good at all if it doesn't reach the most vulnerable people. And what we have now, for some of the interventions I'll talk about, is really falling flat on our faces in terms of implementing some of the things that have such great potential. I have this cognitive dissonance going. The infectious disease meeting was in Boston a month ago, learning about all the new tools and implementing them. And then getting back to my regular office in San Diego and having my CEO and CFO tell me that we're not actually going to purchase any RSV vaccine or COVID vaccine outside of the limited programs such as VFC that was mentioned before. So the equity lens here, we sort of took up that mantle during COVID, that if you look at the lowest quartile of Americans, the health disparities are just obvious, and we have to have sort of more of a equity lens in our approach. And we briefly did have a honeymoon when everything was federally procured, the tests and the monoclonals and the vaccines. It was great for those of us in FQHCs that are doing this work. When things go to the commercialization, boy, it goes right back to where it used to be. And we have data in California that whether it's COVID vaccine boosters, whether it's accessibility of monoclonal antibodies, other things, Paxlovid or nirmatrelvir or ritonavir, as it gets commercialized, we're going to head right back to where we were. So just a brief snapshot of what it's like on the front lines for me in terms of surveillance and diagnosis and therapeutics and prevention. I will admit I'm a subscriber to Caitlin's email listserv. It's a great resource. I have to inform the 200 providers that I work with, so I pull from sources like that for national data. We are very lucky in San Diego to have a robust surveillance system using wastewater for influenza, RSV, and COVID, and a respiratory virus surveillance report, which is put out, I think it's about every 2 weeks, that has 13,000 subscribers that the county has really invested in with COVID funds and really continues to put out numbers on cases, hospitalizations, outbreaks, and the wastewater prevalence of those three viruses. We also have a children's hospital, Rady Children's Hospital in San Diego, that has a very strong virology department. I did some of my medical school research with them, actually. And they have a panel of 13 pathogens, most of them viruses, but even pertussis and other bacteria, mycoplasma on there. And they publish a weekly surveillance report as well. And boy, we're seeing the RSV is going vertical already in the children's hospital there. It's nice for me to be able to tell our providers about that. But again, these are various sources, and to have them coordinated so that there can be good communication out to the public would be wonderful. In terms of diagnostics, again, brief honeymoon period with COVID where we were able to push out rapid antigen tests for free to our most vulnerable patients to pre-position them in their homes so that they can do a rapid test and get to care quickly. Now that those stocks are almost all exhausted, I think they're going to get us through this season, but then what comes next is not really clear. In the clinic, we rely on a dual test. That's an influenza and SARS-CoV-2 rapid antigen, a BD Veritor. We don't actually test for RSV. I just asked the pediatricians this morning. They said it's a clinical diagnosis for them, and if they have a wheezing kid or someone who's tiring out, they send them into the children's hospital where a more substantial viral panel is done that I think looks for 7 or 8 viruses. And again, that information is shared with the public. In terms of therapeutics, we haven't talked about oseltamivir, but it's widely available, cheap, generic, and everybody knows how to use it. So that's kind of settled. We're at this transition point with nirmatrelvir, ritonavir, and molnupiravir for COVID, where we still have some supply left over from the federally procured medicines, but we're a little worried about what's going to happen when people are faced with a copay and when they have to go to the pharmacy to get their antiviral. Remdesivir has been an interesting story that we probably don't have time to talk about today, but we are still giving IV remdesivir despite losing hundreds of dollars for every patient that we treat with it because some people cannot take Paxlovid because of drug interactions. And then in terms of prevention, I hate to end with this, but this is where we've just really not done a good job. The nirsevimab or the Beyfortus monoclonal antibody problems have more to do with supply chain and demand, and that's actually great. But we have 5 or 10 doses in our fridges now for thousands and thousands of children who are vulnerable. And we just kind of got caught with our pants down here. I think the season is upon us now, and we just don't have this intervention for this season ready for where it's going to have impact. And then also with vaccines, with the COVID vaccines and with the 2 new RSV vaccines, again, we as a federally qualified health center that serves as the medical home for 200,000 people, we don't even have these available for our adults. And it really is because of a funding gap. We have VFC, we actually have COVID vaccine to give our children, but not to our 70, 80, and 90-year-old comorbid patients. We depend on our pharmacy partners, but I'll tell you, just adding one additional barrier for a vulnerable patient who has to take buses to get to their pharmacy and to their doctor, it's much better to give it in clinic. And unfortunately now, for all of those that are indicated for updated COVID vaccines or RSV vaccines, we basically have to send them off to CVS. And the specific reason for that is because in California, the Medi-Cal program has designated that as a pharmacy benefit and not as a medical benefit. And so that's where you have my CFO and CEO saying, we cannot just pay another $120 or whatever the RSV vaccine is because we get no reimbursement for that. And so I'm glad it's covered, but wouldn't it be great to be offered at both places? So there's no wrong door. And then again, this whole outlook of the greatest public health intervention that there is, if you don't reach the most vulnerable people, it does not have a population-based effect. So I'll stop there.
Okay, so I would say definitely from this panel, a mixture of good news and bad news, but I'm taking away more bad news. On the one hand, better technologies than ever before. The wastewater surveillance sounds like you all collectively think this is a very reliable way, and I would say inexpensive way of tracking prevalence and new outbreaks in a community, and could apply to certainly all of these major respiratory viruses. But behind that, despite having better, lower costs, both direct OTC diagnostics that people can use themselves, the antigen tests, plenty of availability of lab capacity, a lot of people not really testing reliably under our current policies for using these diagnostics, and then the issues with the therapeutics and the vaccines as well. Maybe starting with the diagnostics and informational issues that Anne talked about so eloquently, and you all picked up on as well. And it's very hard to have a change in approach to managing these conditions, with these new technologies if we're not developing and sharing good information about it. And going back to what I think Mandy Cohen said in her comments, a lot of efforts underway at CDC to try to get to more data sharing from labs and people reporting on cases in the healthcare system, and potential for building on these improving national tracking systems and in some cases local tracking systems. But if I was hearing Mandy correctly, she said that their aim, which would be progress, is having just 20 regional areas this year that could report data like you all say should be generally possible to do, even without further improvements in our current technologies. Why isn't that part going faster for using these diagnostic technologies more effectively? Any comments from any of you? And since you started out this topic, maybe I'll go to you first.
Yeah, no, great. I really appreciate the panel, and I sometimes feel seen. I feel like sometimes in public health, we're like, this isn't working on the back end. So it's great to hear Brian and others being able to share what we're really seeing across the country. I think the challenges with diagnostic are multifactorial. So one, it's what you got access to. So Brian was talking about that they do RSV and, COVID and influenza. Most of the hospitals I work at do RSV, influenza, and COVID. So a lot of it just has to do with purchasing power to even just be able to diagnose it. We saw many states start to make things like RSV be a required reportable condition. So we've seen some changes in the required reportable conditions. I think if we can standardize that across the country on what are reportable conditions, we can help to have the infrastructure behind that to be able to have public health be able to ingest what those conditions are. So for example, our state recently had RSV go forward as a reportable condition. And it was fascinating last year to watch how many older people who had just what I thought was a runny nose, cough, and congestion really had RSV. And so we don't know what we don't know. And so if we're able to have those diagnostic tests that are there. I think another real challenge is being able to see what's happening in the over-the-counter space. And so even being able to see things like what is the uptake in purchasing of over-the-counter rather than how many are positive or negative I think sometimes we become so focused on like knowing what Johnny's results are rather than knowing what the Johnnies of the world are doing. It would be very helpful to have another data source to say how many purchasing of over-the-counter tests are happening and how can we mirror that with how many emergency departments for influenza-like illness we're seeing, and we can mirror that with how many respiratory pathogens that we're seeing that are reportable, and can we mirror that for the hospitalization when they're doing a big RSV or a big respiratory viral panel. So I think we need to stop thinking about like one data set that we need and how can we bring numerous data sets to be able to give us a much larger picture, particularly in the diagnostic space. And then I want to highlight what Brian said about being able to make sure this is accessible. We are just consistently seeing now that this is all in the private market, and it's been really great to have pharmacies stand up and wastewater. Again, I represent all states and territories as the past president, but as a Alaskan, my major one city is debating about even continuing their wastewater testing because they don't have funding for it. Most of our communities are on well and sewer and have no access to it. And I've only got 6 communities that have a large CVS, Walgreens, or some sort of pharmaceutical chain within it. So most of my state, those things are completely inaccessible. And so I think we need to think about these small numbers and rural numbers, and we need to think about other data sources such as purchasing, hospital capacity, as well as the ILI data to be able to have a better sense of what's happening overall. I would also love to see more FQHC data being able to be braided in to see how many urgent care patients are going in, how many primary care patients. I think there's a lot of good Medicaid data and HRSA data that CDC and others could braid into this space so we have a better sense of what's happening, not just in hospitals, but happening in the primary care and urgent care space to know what's happening in the diagnostic and testing space.
Thanks, Ann. Other comments that you would like to add?
Just make a brief comment on home testing. It's been a real success story for us to get people in early because we know how important that is for treatment, for COVID especially. But you do lose that, is that diagnosis captured, and is it still reported to the public health department? That's where things like wastewater surveillance become critical because everybody has to go to the bathroom, right? So you're going to capture those.
Well, I thought Sid's comment about the wastewater looking like it tracks really well against the lab-reported tests, and we can get the information from people, the home tests. Seems like the main value of those home tests, if you've got wastewater, I take Ann's point about we don't have that reliably yet, is to help people know if they're infected for their own treatment and also for changing how they might affect those around them.
And just to, Ann mentioned FQHC data. We are very good at responding to data requests from HRSA because they are our funder, and we have to report HEDIS measures and UDS measures constantly. So if you really wanted to make an impact, you would, I'm trying to get some viral hepatitis markers on there, but respiratory virus diagnostic markers, we could be required to report those, and I hate to put another reporting burden, but it's not that hard to pull from our medical record.
We may have to have you back for our next panel on these topics. I did want to spend a little bit of time talking about the therapeutics and the vaccines, and I'm just going to oversimplify maybe some of the comments, which is great technologies available now, better than ever, but since the public health emergency, we've kind of gone back to covering them and paying for them and having co-pays for them more like traditional medical products for individuals where there's some individual benefit, but there's generally a co-pay expected. Is that about right? And if so, I see heads nodding. So Brandon, you talked about, we should be thinking more quantitatively about these therapeutics and other products, like for people who are at high risk, the number needed to treat from terms of a health benefit for them and maybe saving some of the costly complications from these conditions would be considerably lower. As we'll get to later in the day, we're going to be thinking about number needed to treat from more of an external standpoint. If earlier treatment, less disease spread, et cetera, would make a difference. How do you justify, I'm looking at Brandon, but for all of you, how do you justify moving away from that kind of traditional healthcare, non-public health emergency reimbursement strategy for products that do have effects, not only for the individuals who use them, but people around them?
Yeah, I think that was one of the most important things that we learned during the pandemic was this public-private collaboration, because public health looked at it as a tool to decrease transmission, very much a population health measure. And on the healthcare delivery side, we're looking at it in terms of resource availability and mobilizing these resources and focusing them on patients who are most likely to benefit. And we really need to marry those two strategies up going forward so that we're using them both in the healthcare delivery setting, but also as a public health effector tool. And I think if we're able to do that, that will actually achieve the most cost-effective deployment of these therapies, especially as they become more commercial or we're making policy decisions about whether to purchase them or to deploy them in a public health manner. There will still and always will be populations for whom these therapies work the best. And if we're thinking intentionally about deploying them towards those populations, then we can think, okay, how can we really drive uptake in those populations? Because it's not about treating everyone. You can treat everyone and get the same bang for your buck as if you're treating that specific population who are most likely to be hospitalized, have severe illness, have downstream consequences, drive cost, have population health benefits. And that's not just the high-risk group either, it's also the disadvantaged populations. So I think we have to think about it in two different ways, and it really does require us to be more intentional about how do we deploy what we have to achieve the most good.
And getting the supporting information, evidence behind that. I do want to hear from the rest of the panel on this general topic, but let me extend it, just looking at the clock too, to vaccines as well. So I think restating what Christian said, and we had these bulk purchasing arrangements for COVID vaccines during the public health emergency, which meant, from a manufacturer standpoint, a substantially lower price per unit, but a lot more units compared to where we are now in sort of the non-public health emergency respiratory threat situation. And I think you all mentioned this, that you were projecting out uptake of the COVID vaccine at 17%, reduced but not very correlated uptake of flu vaccines. I can say from looking at some of the manufacturers' own projections that they do for their financial reporting and things like that, they're expecting the same thing, not very high uptake, which in turn leads them to, and I'm not justifying this, but saying, well, look, the price, of course, is going to be higher outside of this emergency setting because we're expecting the uptake in our healthcare system to be so much lower. So how do we get to a different place here where the price per vaccine or treatment goes down more? It seems like it needs to be linked to, though, some further steps in our healthcare delivery system to help people get, Mandy talked about counseling support that CMS is providing for RSV, help with improving access. That seems like a change in the payment and delivery side too, some changes in expectations. And I guess I'm starting at the end of this panel because you guys are on the front lines of dealing with all this. Well, how do we get to a different place if there's this lack of trust and providers feeling like they don't have time to maybe engage with people on this? I'm not sure who else is going to be a source of counseling advice about using these products more effectively.
Yeah, and you think about, if you step away from vaccines for a second, you think about Paxlovid, it's going commercial soon. That will be the same issue. Same pattern, issue. Yeah, it will become essentially. When you think about pharmaceuticals, it'll become what we think of as a brand drug, which is, no one in care delivery makes money off of those things. That will become a real issue from an access perspective. What we pride ourselves in pharmacy is, we're not everywhere, but we are in a lot of places. And, we provide access to a lot of people, but it would become really challenging. I think what worries me about the pandemic and where we are today is how quickly we've lost the lessons and what worked well in the pandemic. It almost seems like an eternity, well, that's all good for us, we can all be together. The public, to Brandon's point, the public and private partnership, amplifying what we bring. We bring access, we bring speed of delivery, figuring out the payment model and ensuring that care delivery is reimbursed. We figured that out in the pandemic, right? It wasn't perfect, but we figured it out. We were able to make sure different stakeholders had their objectives met in order for us to deliver the volume we did. We've gone backwards a little bit, and I think that's what hopefully the rest of the session we start to talk about. From our perspective, our pharmacists are one of the, and I speak with lots of bias, so I apologize, but our pharmacists are one of the most underappreciated healthcare delivery pieces of the healthcare delivery system, and reimbursement is a real challenge in pharmacy. So you are hearing the news about all the different pharmacies and the challenge they're going through. Our ability to provide care is dependent, just like your ability to depend on care. The same decision you're making on RSV, pharmacies will start making those decisions, and that's just not a great place to be in. So I think tighter coordination with the government, tighter coordination with the CDC is going to be needed to take out some of the stakeholder biases that exist in the system right now.
Just briefly, I'll add that I'm glad Director Cohen mentioned the vaccines for adults. There's really a problem right now that adults have to depend on their insurance and the marketplace to get these vaccines, which are potentially going to save us hospitalizations. I know we're talking about...
But just to clarify that further, so many of these vaccines are required to be covered by insurance and without copays, but it sounds like it's still a barrier. That's what I was asking about.
Yeah.
Is it the delivery side? Is it just not coordinated enough to make it easy for the person?
It's the underinsured and uninsured
Yeah.
that the WFC solves for, the vaccine for children. We don't have that program for adults. Yeah. So that's what the bridge program does, but to her point, it's a bridge program.
Yeah, exactly. And we'll, time will tell what copays are out there for vaccines like the RSV vaccines that are there. Yeah. But it's a guaranteed way to increase the disparities because people that are well insured are going to go and get them, and people who are uninsured or underinsured will not. And that's really just not a public health strategy. And we're talking about vaccines here where it would be so much better to prevent a disease or prevent a hospitalization than to have to treat it on the backside and treat the complications of this. One sort of devil's advocate point here is that I'm not sure that we're going to get prevention of transmission. The COVID vaccines in the first trials really showed low infection rates, but that was a little bit of a false promise. It really was preventing severe disease. You can't prevent the car crash, but you can prevent the death in the car crash with the airbags. That's kind of what the vaccines are. And so I think Caitlin mentioned this, that with RSV products, it's probably not going to have a huge impact on transmission. RSV is a very transmissible virus, but it will certainly reduce. I was a pediatric resident at Duke Children's Hospital once with hundreds of kids waiting to be admitted for RSV, and they just sat there for 3 or 4 days until they got better. That is a huge burden on our healthcare system, which can be very easily impacted by some of these products. So maybe not transmission, but hospitalization and cost to the system are important outcomes.
Caitlin, thoughts you'd like to add on this topic?
Yeah, one challenge with vaccine delivery that I maybe haven't heard yet, I've heard from many pediatricians who were thinking about stocking the RSV product for infants that they didn't know what demand was going to be. They didn't know how many families would want it. And so they were reluctant to invest in keeping the product in the fridge, not knowing if they would get that money
Well,
back.
that kind of became a self-fulfilling prophecy, too. It's like if you
the problem
don't have
really,
an
it ended up
infrastructure
being
in
the
place,
opposite
yeah.
problem,
Yeah.
which is that more families wanted it than was product available. But I think it emphasizes your point, Mark, that you can't have a population health strategy that relies on individual providers, small practices, to do all of the things of public health delivery. And so if you look at, for example, many of the pandemic preparedness plans, strategies, reflections that have come out since the pandemic, many of them focus very heavily on medical countermeasures. We're going to develop this vaccine. We're going to invest in therapeutics. We're going to do all the diagnostics. What they don't talk about is public health. Who is going to deliver those products? Who's going to pay for them? How are we actually going to get them out into communities? And I think that's one of the biggest gaps. One of the themes I'm hearing from my co-panelists here is really that part of the strategy. So I think that's so important.
Yeah, and I think as we get to sort of points for final thoughts here, and maybe I can go down the line, just a couple of points to add to that. So where is public health in this? Well, a lot of these new technologies are delivered through healthcare, and we're now living in a healthcare world where if you listen to the leadership for many of our healthcare organizations, they're saying, well, we need to move from being reactive and paying for the expensive complications downstream, get better at our primary healthcare, get better at our partnerships in communities for people who are at risk. the versions of advanced primary care really are about, I think Ann used the term, population health, and some, Kristen, you mentioned some accountability around that for FQHCs. FQHCs are primary care providers for some of our most vulnerable American citizens and residents. So I would like to ask just maybe one question on the issue of transmission and technology. So as you pointed out, for some viruses, it's just harder to reduce transmission than others. So that may be a virus-specific issue. If you can't do it via the vaccines, how do you get transmission rates down for those viruses? And any other thoughts that you all would like to close with? And since you just spoke, maybe I'll start with Ann on this one and then go down the line.
Yeah, again, I think it goes back from my perspective on braiding population health, taking public health and healthcare and working together. So it's everything from the way that we're delivering care. I think we were talking a lot about the distribution challenges. I think not only is it payment and reimbursement, but it's also the complexity for the individual. So one pharmacy might be in network and another pharmacy might be out of network. So we've got patients even bouncing back and forth between different pharmacies. Or we've got one family practice clinic that may be offering, services to lots of different insurers, and they have all different types. And so they can't manage the diversity of different payment structures and what that ends up looking like. So I think and that's what we saw when the government bulk purchased these, is we were able to get them out. So I think we need to make systems, again, work for people instead of asking people to be like, well, what type of insurance do you have and what component and where do you go? How can we braid that? And I think public health in state departments has an ability to actually be able to braid more of that together if they have the understanding of the way that the healthcare sector works, which is not a part of training within public health. So I think that gets back to just how do we think of this as a health system instead of a healthcare system and a public health system. Using similar language, like the number needed to treat, I think is great messaging for then the comms component, like who's going to be most valuable, who's going to be most beneficial for having this vaccine or this treatment. Instead of public health just saying, everyone go ahead and go get your vaccine or go get treatment, being able to speak to it in a more nuanced way. I think a lot of Dr. Walensky's comment that when your head's in the fire and your feet are in the freezer, your temperature may be average, but you feel really different. And I think that is really what we're seeing both in the payment structure as well as the communication structure in this country, particularly now as we've entered into the private market and we've moved away from kind of this bulk, nationwide response. So we've got to make sure that our messaging as well as our treatment really responds to the needs of that individual person. Thanks.
Great, thanks, Ann. Sid, final thoughts?
So as we think about all the stuff that Ann talked about, the complexity of delivery, the in-network, out-of-network, all of those things, we're essentially making our problem the patient's problem. And what's happening right now is we actually have an education problem. Like we have an adoption problem. We have, what we found is some of the most highly vaccinated counties are also some of the most high-income counties in the country, and they have traditionally always been the case. Right when the RSV vaccine and the COVID vaccine launched, they were launched at the same time. Our pharmacies were overwhelmed, but they were overwhelmed in certain parts of the country. In other parts of the country, we had tons of vaccine or availability. So what essentially we are running out of time is, the longer we take to figure this out, the more we will lose people on the effectiveness of these tools. If we take 3 or 4 years to figure out, these are no longer innovations, right? What will happen with flu vaccine will happen with some of these other vaccines. So I guess my parting point is urgency is what's needed. I think we can't rest on the COVID pandemic and say we figured this out. We actually are quite at an inflection point right now.
Thanks.
Briefly, I'll just say that a population or a public health strategy is only as good as it can solve the needs of the most vulnerable. And where I work, it's the multi-generational household that has poor ventilation. We didn't talk about ventilation, but a senior who may or may not have cancer chemotherapy, an essential worker who has to keep working and can't get sick leave, and a kid or 2 or 3 that are in daycare. So talk about viral transmission in that household. If our strategies are not going to address those types of needs, they're not going to be effective in the long run.
Thank you.
I think fundamentally, public health and healthcare delivery are still at their core an issue of motivation, of behavioral change. So I'd like to challenge us to think upstream of some of these interventions and to think not how much of a disparity do we have getting vaccines to people, but why are people not seeking vaccination? Why is our test-seeking behavior the way it is? Why are we seeing big gaps in the way we have distribution and allocation? Because I think we've got the right tools, and we've got the right ideas, and we've got the right personnel, but if we keep doing things the same way, we're going to get the same result. If we can take a step upstream and say, how can we modify behavior by changing our strategies, our incentives, and our policies to actually drive the behavior, then I think we're going to actually achieve what we want, both on the healthcare delivery side and on the public health side.
I'll just pick up on the points of my previous two panelists and say that when it comes to behavior change in public health, we know it's really hard to get people to do things consistently and correctly. And so I think ventilation is actually the strategy that is most viable in terms of a non-pharmaceutical intervention that can reduce transmission. It is expensive and it's very hard to reach every building, but it benefits everyone in that building and does not rely on individual behavior change. And so I think that is really part of my vision for the next chapter in public health.
All right, well, I want to thank you all for your vision for where we are now and how to get to that next chapter in public and population health supported by better biomedical technology. You've given us plenty to talk about in the next panels, which we're going to go to right now. Thank you all so much.